So my name's Fenton. I am an instructor with Coast Wilderness Medical Training. So I'm a certified Red Cross Wilderness First Aid instructor, paramedic with BC Ambulance, and a instructor guide in a number of things. I will apologize. I am a lapsed sea kayaking guide. I got sucked into the world of whitewater paddling far more these days. So I don't really do a lot of sea kayak guiding anymore, but former guide. I also teach a lot of avalanche rescue, swiftwater, things like that. So for the next little bit, I'm going to run through a little bit of an introduction to wilderness first aid. There's going to be some photos and talk about blood, real injuries, things like that. Unfortunately, this won't be as engaging as an in-person version of this workshop where I bust out a large bottle of colored corn syrup and play with a lot of fake blood. But just also to be super clear, like this is not a formal first aid course. This is kind of just an introduction to a lot of the concepts to get folks thinking about a lot of what comes up when we talk about like managing medical and traumatic emergencies in the wilderness. So yeah. We're going to focus a lot on trauma, just because it's sort of the one thing where I can talk and kind of tie things up in a neat little bow within 1 hour, but it's only a little kind of sliver of the whole world of what we deal with when it comes to first aid and medical emergencies in the wilderness. Talk a lot about case studies, myth busting, kind of hopefully give you like a little sample of what you might get if you were to participate in a full course. So just wanted to kind of acknowledge, we heard a lot from the other Cam already, just importance of recognizing Indigenous lands, Indigenous sovereignty in the lands we recreate. And it's also, I think, worth noting when we talk about this and talk about mountain medicine and mountain rescue, that mountain rescue and wilderness rescue has its roots in Indigenous communities in Canada as well. The first recorded successful mountain rescue was carried out by 2 Indigenous men, members of the Stoney Nakoda Nation, which is out in the Rocky Mountains in what is now Banff National Park. Their traditional territory is kind of Banff, Lake Louise, and Kananaskis area. A young climber fell on Mount Lefroy, which is up near Lake Louise if you've ever been there. And these 2 guys canoed across Lake Louise to rescue him off of the glacier. And this is also just the first recorded story. You know, there's a lot beyond and before this that is not necessarily written down in the history books. So talking about kind of the basics of wilderness first aid. So wilderness first aid is a sort of a pragmatic, principles-based approach to medical care in austere, remote environments. So big thing when we talk about wilderness first aid is that perfect is always the enemy of good enough. We're never going to have all of the supplies, all of the tools, all of the medication we wish we had in the wilderness. We're not in a hospital. We don't have X-ray eyes. So we always need to be thinking about that when we're engaged in the wilderness first aid. The other thing about wilderness medicine is it's a constantly evolving practice. You know, the more that we have people recreating in the wilderness, the more we have very well-trained search and rescue teams, the more things that are happening, the more we learn about the pathophysiology, things like that around medical emergencies in the wilderness. So the more we can develop better and better practices. So basically to say that, like if you took a first aid course even 3 years ago, there's a good chance a lot of things have changed in modern wilderness medical practice. And when we talk about this, we need to kind of recognize the biggest differences between urban and wilderness first aid. And the really big thing here is that in urban medicine, and even when I work on ambulance, even up where I work most of the time now up in Pemberton, we're still usually within minutes of getting to advanced medical care. Whereas when we're in the wilderness, we're at least hours, if not days, from advanced medical care. So that really changes how we have to think about things. We have to think about evacuation, long-term care, stabilization, and we also have to think about the elements. We have to think about the fact that we're often in colder, wetter environments without access to shelter in the same way we have in a situation. Even if I'm, 50 kilometers up a logging road working up in Pemberton, I still have at least an ambulance with me, which is a nice heated sheltered box I can do the work inside of. So brass tacks of wilderness medicine, we're going to cover all of these points in this little presentation, but this is kind of the key pieces to take away. So first, trauma is a surgical disease. So when we talk about trauma, really what we're getting into is that it needs to be dealt with in a hospital. The second one, move if you must. We'll get more into that. Air goes in and out, blood goes round and round. We'll talk about this thing called the wilderness hourglass, and get into it from there. So trauma as a surgical disease. So this is a very interesting rendering of an X-ray of a pelvis. Pelvic cavity is one of the largest open spaces in our body. It also contains some very high pressure blood vessels. And damage to the pelvis is quite dangerous and life-threatening. And what this really gets into is that in order to deal with major traumatic accidents, like a fractured pelvis, you really need surgical intervention. What fixes this is not anything that we can provide in the field. What fixes this problem is the bright lights and cold steel of hospital surgical rooms. So what we're doing when we think about first aid is we have to think about slowing down processes that are bad for our patients. We have to think about evacuation and transport. So slowing down and stabilizing people for as long as possible and getting them out of the wilderness. The joke we kind of often make in wilderness medicine is that the most important medication or treatment for anyone in the wilderness is diesel therapy, meaning they need a helicopter, a boat, or something with an engine that can get them very quickly to some advanced medical care. So one thing in here to give a sense of it is this case study. So this is based on a real case study, but thinking about, adapted for this situation. So 25-year-old slips and fall on a 20-foot tall rocky shoreline. They're 18 kilometers from a local trauma center. There's no cell phone reception within 2 kilometers paddle from where it happens. The patient's initially unresponsive, has a brief lucid period, followed decline to coma and cardiac arrest. Initially, a paramedic is flown in and is able to return pulses through needle decompression, which is a fancy advanced care intervention you don't really need to know it about. But the patient eventually dies during a 2-hour delay in access due to a delay in access to search and rescue helicopter with long line capabilities to fly the patient out. So what this kind of gets to is the inability that, like, in this situation, and this is based on a real situation, the difference that could have been made for this patient wasn't any kind of advanced medical care on the scene. It was the ability to call for rescue. So the fact that someone had to paddle 2 kilometers to get to a cell phone service and call is the delay that actually potentially is the life changing intervention that comes in here. So when we talk about what could have been done differently, what really could fix this in this situation is the ability to call for help earlier and faster. So this is kind of what explains why. So this is something from emergency medicine in the ER department. And from a research that went into search and rescue, kind of supporting the increased usage of helicopters in search and rescue operations. And so effectively, if you look at both of these, what it shows is that survivability rates or percentage of mortality rises dramatically the longer that paramedics are on scene or rescue personnel are on scene, and the longer it takes to dispatch additional resources to the site. In ambulance work, we call this the golden hour. And basically what that means is that in instances of major trauma, we have an hour to get a patient from the moment of accident into a hospital emergency department and begin definitive care. So obviously one of the challenges we have in the wilderness is that we actually rarely can deliver evacuation within 1 hour. So a lot of what we do in wilderness first aid is about turning this golden hour into the golden 2, 3, 4, 12, 24 hours. It's about figuring out how do we extend this period in order to keep someone compensating and alive long enough to get them to the definitive care they need? So when we talk about this, we ask, like, what makes the difference in emergency care? And what this kind of boils down to is it's not actually the stuff on the left, it's the stuff on the right. What really makes the difference is not kind of all the fancy things we see on TV and televised medicine shows. It is diesel therapy. It is the ability to get people to advanced medical care. Not to say there's not things we can do that are critical, but what we're doing is we're stabilizing patients. We're not treating, we're not fixing the problem most of the time in the wilderness. We're providing stabilization in order to buy time for evacuation and definitive treatment. So in here, big key things to take away from it is whenever we're going out, we need to have an exit strategy, have communication devices, and understand where we are and what kind of local resources can come and help you. So in this situation, it's kind of like a big thing is understanding when you're going out paddling, what Coast Guard resource, Canadian Forces resource, like is it the Cormorant Squadron out in Comox, or is it the Royal Canadian Marine Search and Rescue? Who is it? Where are they coming from? And what kind of response capability do they have? And that's really going to kind of determine. And so you might need to think about things like, do they have vessels or air or helicopters that are capable of flying in bad weather, poor visibility, or capable of getting to you in bad sea states? Thinking about these kinds of things, like what could delay rescue? Knowing all this kind of stuff really plays a really critical role in figuring out and planning for it, and building that into your emergency response plan can play a really critical role in actually improving and changing patient outcomes, particularly in instances of like major accidents and major trauma. So when it gets down to wilderness medicine, which we can talk about, is like, what do we do in the meantime? So what do we do in order to extend that golden hour into the amount of time we actually need to sustain a patient for? So key thing here, moving people if we have to. One of the kind of common, a big common thing that really got pushed for the last couple decades in wilderness medicine and all kind of pre-hospital care is a lot of kind of fear around moving people, particularly as it relates to spinal injuries. So this is kind of another case study. This is from an accident that happened nearby Squamish a few years ago. So a group of climbers are up in an alpine setting. They encounter a loose rock. The lead climber falls and hits his head on a rock. He's suspended in his harness upside down, initially unresponsive, and eventually starts complaining of numbness in the legs and a severe headache with difficulty breathing. His breathing becomes labored. You hear snoring respirations, indicating that this patient is losing consciousness. SAR is contacted immediately, but is delayed due to the difficulty of access. The big question here is, would you lower this person? And at one point in time in wilderness medicine, the standard would be probably not, because we're super concerned about a spinal injury. But one of the things we need to remember is that spinal injuries are not, they're not life-threatening. They're potentially life-altering, but they're not life-threatening. This person has a compromised airway. Air is not moving in and out the way it should be. So we actually need to move this patient in order to give them the definitive care they need. So, thinking about this and thinking about that, like oftentimes moving people is going to be a necessary part, and we have to think about how, when, and why to do that. So that's the big one. The spinal injury, the fear of spinal injuries has kind of been a pervasive thing in emergency medicine for a long time. And in the last few years, what's happened is there's been a lot of reviews of clinical guidelines, of papers, of patient outcomes. And what we've learned is that there's been a lot of kind of mythology around spinal immobilization, in particular as it relates to major trauma patients or folks having respiratory emergencies in addition to spinal injuries, that people end up, because of their fear of spinal injuries, they don't intervene and address actually like critical life-threatening emergencies, particularly as it relates to airway compromise. There's been a bunch of studies that have shown that what we do in terms of spinal immobilization is actually either not helpful or potentially harmful. And so one thing we've seen is that it used to be that these hard backboards were the standard. Everyone who thought of a spinal injury had to be strapped to one of these. That has been almost exclusively phased out of pre-hospital medicine. The only really use of these backboards now is they're used in some water rescues in order to get people out of the water, but they're almost never is a patient kept on a backboard, because what's been found is that these actually increase mortality and increase negative outcomes when we're using backboards. And other things have started to put in the collars we use, other pieces, they're increasingly being shown to not be as effective. So effectively, what this kind of boils down to at the bottom line is that moving does have risk to a person, but leaving someone in a dangerous position also does, particularly if there's life-threatening risk. So in here, the other thing to remember is that improvised methods may actually be better than what we use on the ambulance. There was a study done comparing North American EMS to EMS in the Philippines in terms of outcomes from spinal or secondary spinal injuries. And what was found was that there was effectively no appreciable difference between the amount of secondary spinal injury in the Philippines and North America, where in the Philippines, they throw every patient just on a stretcher and take them out, where in North America, we have a kind of very structured approach to spinal injury management. At the end of the day, we have to move patients. And sometimes it's because maybe they have an airway issue. Other times you could think about just having to move patients because of environmental concerns. Maybe the tide is coming up. Maybe a storm is rolling in. Maybe, we're going to be able to better manage and care for someone in a different location where we can set up a shelter and deal with things like that. And so movement is really kind of a critical piece of it. So don't talk yourself out of a perfectly reasonable course of action. Just because people are hurt, it doesn't mean they're helpless. The big thing here is like slow is smooth, smooth is fast. So we have to move if we need to. It's a nice little animation of packaging up a patient for extrication. You can see a lot of preparation. Everything is done quite like smooth, effectively, cleanly, and quickly. Also, a lot of the time when we go through these courses, some of the most fun we have is learning how to move patients in and out of different places. So, one thing you might be able to play around with in a kayak specific course is talking about how you could build a like cataract out of a couple sea kayaks in order to float a severely injured patient out or tow them out if they needed to be kept supine. Played around with it a little bit, and it's kind of fun thing you can mess around with. Cool. So next concept that's really key to this is air goes in and out. So in order for life to be sustained, air needs to be able to go in and out of the body. And if you don't have an airway, you don't have anything else. Airway management is kind of one of the critical things we think about when we're dealing with wilderness medicine. So in here, another case study. So 45-year-old is thrown from his mountain bike while descending at high speed, impacting his head. Other folks find him unresponsive with loud snoring respirations. He eventually turns blue in the face and bystanders begin CPR. So we think about what could have been done differently here. Think about this. This person has gone into cardiac arrest because of respiratory failure. So if they had actually managed this earlier by actually just opening the airway and ventilating this patient with rescue breathing, you likely would never have to get into a situation where you have to begin cardiac resuscitation. And it potentially has a much higher chance of saving this person if you catch this earlier and manage that airway, manage keeping air moving in and out. Simplest thing to remember with airways and air moving in and out is that a noisy airway is an obstructed airway. So airways should sound like breathing. So it should sound like or quieter. Any other sound is a problem. It's indicative of an obstructed airway of some kind or another. This image just shows kind of what it looks like. And the big thing here, recognizing that especially within trauma, is that when patients lose consciousness, they lose the ability to maintain their own airway. And so we have to do manual airway maneuvers to maintain it. Take the course, we spend a lot of time practicing airway maneuvers, rescue breathing, all these kinds of things. It's also a really key concept to understand because airway compromise and being able to move air in and out, rescue breathing and artificial ventilation is kind of also the bread and butter of resuscitating folks who have drowned. So resuscitating immersion, after immersion, because I play after saltwater immersion, really high quality and having a strong ability to understand how to do manual airway maneuvers, open an airway and effectively ventilate someone is really the critical life-saving intervention for dealing with water immersion, especially cold water immersion. So other key thing related to principles of wilderness medicine is that blood goes round and round. So if blood is moving in or out of the body, we have some kind of a fundamental problem happening. So see if this little video will play here really quick. There's no sounds, it's in Italian anyways, but hopefully you'll be able to see it. Oops, go. Fall, somehow impaled, kind of a little junctional injury in the joint there. It looks like they've lacerated an artery, a lot of bleeding. You can see here, it needs to put a ton of pressure on. So hands aren't working. So actually just like dropping his knee on and putting entire body weight worth of pressure onto this thing. So key thing here, take away from it, is that the leading preventable cause of death in trauma is bleeding. Basically, in order for us to continue to stay alive, we need to keep blood in our body. Average person has between 3 and 5 liters of blood in our body, depending on the size of the human. Once you start losing more than half a liter to a liter of that, we start dealing with hypovolemic shock, and that creates some major challenges for sustaining life, because if we start losing that volume of blood, we're unable to keep our core organs perfused. That perfusion is what brings oxygen and sugar to things like the brain and the heart. And if those muscles are not getting the fuel they need, we just can't keep going for very long. So dealing with bleeding is a really critical part of it. And a lot of what we see in the wilderness is accidents related to this, especially camp accidents, cutting wood, making dinner, things like that, anything where we're using sharp objects, but also like slips, trips, falls. When we experience these things and they become, more than just the little cut that gets easily managed, that's where we see a lot of life-threatening emergencies in the wilderness. So how to stop a deadly bleed? First, push down hard. So we want to add a ton of pressure. So well-aimed direct pressure on the wounds, adding bulky dressings as we do it. And we're always adding dressings on top, pushing down until the bleeding stops. We never replace dressings. So if you put a dressing on it, you leave that on and you add on top, because what we don't want to do is pull it off. That starts to remove the clotting factors that are helping to control that bleeding in the body. We want to keep pressure up, never letting it off, so that we can just like really, really try to stop that bleeding. The first clot you need to keep building up on top of it. Make pressure dressings. So that's where we take a tensor bandage and wrap it to keep pressure on the wound, even after we think bleeding has been stopped and it's not bleeding through anymore. The last thing is don't be afraid of tourniquets. Whether using a commercial one or an improvised tourniquet, there used to be a ton of fear in wilderness medicine around tourniquet use. And what we know now is that a tourniquet that is applied for 6 hours or less has never led to a loss of limb. And even above that, the numbers are in the 2 to 5% at 12, 24 hours and beyond. And at the end of the day, it is life over limb. If you need to use a tourniquet and don't because you're worried that someone might lose a foot or an arm, well, they're going to lose their life if we don't stop the bleeding. So tourniquets are a pretty important thing. They're pretty standard in most professional first aid kits now. And I, as a guide, always carry one because this is kind of that situation where if it happens, it's not super common, but if it happens, it's really bad. But it's also the thing where I can actually really intervene quickly and save someone's life. So tourniquets, they're always applied above the injury, never over top of a joint. And ideally, they're applied above the knee or the elbow, because in our forearms and our lower legs, we actually have two bones, and the artery in some people runs between them. So what we're really doing with a tourniquet, we're compressing an artery against a bone. So tourniquets, don't be afraid of them. Put them directly above the wound. Don't put them on the joints, and you want to turn it to 11. That means crank it up as tight as is necessary. You keep turning the tourniquet until the bleeding stops. It's not going to be comfortable for your patient, but this is that kind of, oh shit, need to save a life type of intervention. The other thing about tourniquets, once they're on, they stay on. We don't loosen tourniquets, we don't open them, we don't take them off to check if the bleeding has stopped. If we do that, there's a good chance we're going to blow out any of the good clots we have and potentially lose more blood out of the patient. And if we've needed to use a tourniquet, it's because there's a pretty serious problem, and we really don't want to lose any more blood from this patient. Cool. So what this starts to come together in is something called the trauma triad and the wilderness hourglass. So another one to think about, and this I think really kind of relates to a lot of similar things we deal with as paddlers, is getting hurt in wet and cold environments. So this one, again, another kind of sea to sky accident. 30-year-old slips and falls 50 to 60 feet while canyoning. They're transitioning between anchors. They miss an anchor and slip and fall. Land in a shallow pool, suffering an open femur fracture with substantial bleeding. One person rappels into the pool to stay with the fallen member, while another ascends up to activate their SOS device. Despite it being a warm summer day, both members, the injured one and the person who went to go help them, are later found hypothermic, and the injured member bordering on cardiac arrest. So the big thing here is that water creates a lot of challenges. We lose body heat 25 times faster in water than we do in air. And being wet, we are cooling off 4 times faster if we're just wet standing in the air. So why this is so critical is something called the trauma triad. So basically, when someone is seriously hurt, 3 things are happening in the body. Hypothermia, which is body getting colder and colder, core temperature falling. Acidosis, as in this case, is particularly talking about carbonic acid, and that's the buildup of carbon dioxide in the body, which is making our blood more and more acidic. And then the other one is coagulopathy, which is pathy in medical speak means bad, coagulation. So it's bad blood clotting. And if you think about what happens here, as we get hypothermic, our breathing slows down. So as our breathing slows down, we're breathing in less oxygen and expelling less carbon dioxide. So we're building up and holding on to more carbon dioxide in the body. As that happens, that makes our blood more acidic. The more acidic our blood becomes, the less effective clotting is. And as that clotting gets worse, blood moves around the body less and less effectively. And one of the main functions of blood moving around the body is temperature regulation. And so if blood isn't moving around the body, it's going to make hypothermia worse. And as hypothermia gets worse, acidosis gets worse, coagulopathy gets worse, and so on and so forth. So this goes from being just a triangle into a cycle or a swirling toilet bowl of doom. So the other part of this is when we think about wilderness, is the things that make hypothermia worse. So I'm sure anyone who's been on long paddles or done long days out in the woods around here has experienced some version of this, where if you're not drinking enough water and you're not eating enough food, you get colder faster. And so a key thing in here, when we think about it, is that hypothermia is kind of the thing where we have the most ability to manage the problem in the wilderness. So there's three things we can do here. One, we can actively manage for hypothermia with a hypothermia wrap, which we'll talk about in a minute. We can also in here think about if it's possible, if we have a patient who is able to tolerate it, we can keep up our patient's fluid levels and calorie levels in order to keep the energy in their system, fluids in their system, to keep things moving in the most effective way. And so what happens is these things come together. And so we have the wilderness triangle and the trauma triad coming together into the wilderness hourglass. And so when I talked about what we do to buy time, this is really where this boils down into. So we can help with coagulopathy by keeping as much blood in the body as possible. So controlling deadly bleeds using tourniquets, direct pressure, stopping those bleeds as quickly as possible helps us deal with coagulopathy because it keeps blood in the body. It helps to set us up for success. We can help deal with acidosis by maintaining airways. So if the patient doesn't have an airway, they're not bringing in oxygen and expelling carbon dioxide. So managing ventilation and oxygenation through airway management and rescue breathing helps us stay in front of acidosis if the patient isn't doing that on their own. And then the other thing we can do is manage hypothermia, whether that's by keeping our patient fed with and not getting hypoglycemic, keeping their fluid levels up, or just actively managing for hypothermia. So how do we deal with this? Hypoglycemia, hot chocolate is your friend. Hypovolemia, fluids and controlling bleeding, giving tea, things like that. Hypothermia, this photo right here, which is the thing, if you take one of these courses, you'll spend a lot of time playing with, is the hypothermia burrito. So when we talk about this, how important it is, just to give a sense of it, approximately 50% of major trauma patients in urban centers arrive at a hospital hypothermic. Even mild hypothermia results in a 300 to 500% increase in mortality and trauma. So this is really critical for us to understand, particularly as folks who recreate in, wet environments. Hypothermia is a huge problem, and if we have any other injury, hypothermia makes it that much more dangerous. So moderate to severe hypothermia is associated with 100% mortality and major trauma. So meaning if a patient has had major trauma and is moderate to severely hypothermic, there's a strong correlation to almost all of those patients not making it. So that's some references. So it's pretty important. Think about this in terms of how effective this stuff is. This is based on some studies of trauma, and it's how effective different interventions are. So defibrillating a patient in cardiac arrest, 1 in every 2.5 patients that this is done on are saved by it. Preventing hypothermia in major trauma increases the patient's positive outcomes in 1 in every 3.5 patients. Controlling a bleed with a tourniquet, 1 in every 23. Doing CPR, 1 every 24 to 36. Giving pro-clotting medications, this is a fancy intervention that we do on the ambulance for major trauma, only increases 1 in 67 patients. Spinal mobilization, we don't even have data on. It does not do much. And we don't have data showing that it does anything in terms of saving lives in major trauma. So really, like, hypothermia is the thing that we have the skill set and tools to deal with in a wilderness environment. Really critical thing to understand and manage. And it's really effective in terms of being able to save lives. Not sure why. There we go. So, big thing to understand about hypothermia. Hypothermia is not being cold. It is a failure of our body to compensate. So what happens when we think about hypothermia is basically our body has run out of energy to keep our core temperature up. Second thing to understand about hypothermia, it is 100 times easier to prevent it than to reverse it. The ground is your enemy when it comes to hypothermia. I'm sure everyone has had this experience where you sit down on a hike to for lunch, you sit on some cold ground, and in minutes you're freezing, despite the fact that it's like a decently warm day. We lose a ton of body heat into the ground. And we talk about the most efficient method preventing heat loss, or the most efficient method of heat loss. It's evaporation. So evaporation, think of that, wet skin cools off extremely quickly. This is why anytime for folks who travel, recreate, and do things in water-based environments, hypothermia is a thing we really need to be concerned about. And it doesn't really matter even if it's the middle of summer. Our bodies will start to lose body heat at ambient air temperatures of 24 degrees. So a nice moderate summer day, you are potentially actively becoming hypothermic, especially if you are wet. So key thing here, remember the hourglass. Other tool that we have, this is something called the bear hugger. These are how we resuscitate patients. Do that. Cover this. This is the other tool that we have, the hypothermia burrito. So this is kind of the bread and butter of wilderness medicine. So in order to do it, you have to understand the ways that we lose heat. So conduction, convection, radiation, evaporation. So conduction, the ground is our enemy. So when we're building a hypothermia burrito, this is where we want to put a sleeping pad or some similar type of layer that separates the patient from the ground. Convection, that's our insulated heat loss. And so this one, we use a tarp in order to wrap the outside of the layer, protect the wind from blowing through and cooling us down. Evaporation is our vapor barrier. This is where we need to make sure that against the skin, the inner layer of the burrito is an emergency blanket. So what that allows us to do is have a damp patient in the middle of this and protect against evaporation. So those tinfoil looking blankets in the middle, that's the lowest level of it. This is where they play a critical role. And then radiation, this is where our sleeping bag insulation is playing such a critical role in our burrito. So putting these things together will, if anyone's ever been inside of one of these or practiced this, it really is amazing how effective this works as an intervention, and how you can build this with a lot of fairly lightweight materials you can carry with you easily, whether it's on your back or in your boat. So kind of putting it all back together, remember, trauma is a surgical disease. We have to move if we need to. So key thing, major accidents, the key thing that we need to be thinking about is getting this person out of the wilderness, getting them to advanced medical care, knowing how we're going to evacuate, how we're going to communicate with rescue resources, and what kind of resources are around. What is the nearest station? What is the nearest resource? Where are they coming from, and what kind of logistics do they need to deal with? Remember, we really need to think about managing an airway. Air goes in and out. If we don't have an airway, we don't have anything else. So that airway maneuvers, jaw thrust, opening the patient's airway, and rescue breathing, if we don't have that, we're kind of screwed. So airway and breathing is kind of our 1 and 2 in a lot of in basic emergency medical care. Blood goes round and round. If something's bleeding, stop it as quickly as possible. Don't be afraid of the tourniquet. Keep blood inside the body. It's going to allow people to compensate for longer. And then remembering this key thing, the wilderness hourglass. So hypothermia is like one of those things that is the most dangerous, especially for those of us who recreate in wet environments. But it's also one of the things that we can do a lot about in the wilderness, and do a lot about without advanced training or advanced tools. It's really just about understanding that hypothermia is our enemy, and it plays a critical role in worsening patient outcomes. And realistically, it is the #1 reason why things go very bad in the wilderness. Generally around here, people don't starve to death. People don't die of thirst. People die from being cold and wet in the woods around here. So that's the critical thing that we really need to kind of dial in on. And that's what a ton of what we focus on when we do the hands-on training is different ways to deal with these problems.